All right, guys. So hope you're all doing well. Today, this video is going to cover the technique behind spinal and epidural block placement. Just like we've done with every other skill, I'm going to take a few minutes at the beginning, kind of go over the anatomy behind it, explain not only what you're doing, but like kind of the why behind it and why it works. Then after we've done the kind of lecture where I present it to you, we'll get one of the mannequins out and I'll actually demonstrate the technique for spinal and epidural. Typically, we lump these two blocks together as far as a presentation because they're both considered neuraxial blocks. They're both working on that kind of central nervous system area. The epidurals and spinals that you're going to be placing are going to be in the lumbar area. Spinals for sure in the lumbar area because we're trying to avoid any kind of cord damage. But epidurals as well, most of the time are in the lumbar area. So with that in mind, the procedure guides that you have on Blackboard are both written to place these blocks, and they're written kind of from an obstetrical anesthesia standpoint. Because in most institutions today, the vast majority of spinal and epidural blocks are placed in the OB unit for either relief during labor or for a primary anesthetic for a cesarean section. It's not to say you can't put a spinal or an epidural in for particularly epidurals for post-op pain management after some other type of operation, or spinals. That's always a viable option as a primary anesthetic for other surgeries, particularly knees, TURPs, those that have malignant hyperthermia. It's a great way to do an anesthetic for that. However, again, going back to what I said before, most of the time you're going to be putting them in an OB. And so if you look at the procedure guides, they're going to talk about getting a full history, administering a fluid bolus prior, all of that again kind of written, particularly the fluid bolus, written from an obstetrical standpoint, okay? I, for one, when I was in school, I can tell you spinals and epidurals in particular, were the things that made me the most nervous. Because I don't know about you guys, but for me, I had seen a ton of people intubated. I had shadowed in the operating room. I had seen central lines and arc lines put in hundreds of times, assisted with those in the unit, that sort of thing. Never once seen a spinal or an epidural, so it was totally foreign to me. And with that in mind, it made me very nervous. So I'm going to try to hopefully dispel some of that fear, if you guys are feeling the same thing I was feeling, by going over again kind of what you're trying to accomplish. And the anatomy behind it, if you understand the anatomy, it can really take those fears down to a reasonable level, all right? And by that, what I mean, one of the biggest things I was afraid of is, what if I screw something up and I paralyze somebody with this, all right? To dispel that fear, if you're putting in a spinal or an epidural in the lumbar area, not going to paralyze anybody, all right? Spinal cord ends in L1, most individuals. There is a small percentage of the population where it extends to L2. So what I'm going to present to you today is a way to place these blocks below the level of L2. And when I say L1, L2, I'm talking about the lumbar spinous process that defines that inner space level, right? Or that level of the spine. So if you place these blocks below the level of L2, there's no spinal cord there, and you don't have to worry about paralysis. Now, that's not to say that you can't still cause damage. I mean, you can cause paresthesias, you can cause cauda equina syndrome, all of that kind of stuff, and you'll learn about all of that in your regional class. They'll go over all the risks and benefits to these blocks there. But the biggest block, or the biggest risk, or the biggest fear, I guess I should say, not really risk, but the biggest fear that most students have when they're learning these blocks is, man, I don't want to paralyze anybody for life. And what I'm telling you is, if you're putting this in below the level of L2, you don't have to worry about that because there's no spinal cord behind that dura that you're going to hit, right? So, how do you know where L2 is? Well, let's take a look at our mannequin right here and I'll show you. All right, so on this mannequin, It's set up to show you the spinal canal. Obviously, it's not entirely anatomically correct as far as the sizing of these vertebral bodies and some of these vertebral areas here. But what I'm going to show you is how do you know where you're putting a spinal or an epidural block in, right? Because I'm telling you to put it in below the level of L2. Well, how do you know where that is, all right? So what you're going to do with a patient sitting up, you can do it with a patient lying down, but sitting up is the best way. You're going to look for anatomic landmarks, just like we have with some of our other skills, right? So when you're looking for a central line, I'm telling you to look for the sternal notch. I'm going over how to find the carotid artery. You're going lateral to that, all that sort of thing. So with a spinal or an epidural, you're going to be looking for anatomic landmarks. The ones you're going to be looking for is the top of these iliac crest, all right? So you're going to come up to the patient, you're going to palpate, and I'm doing this obviously from the wrong side because I want you to be able to see what I'm doing. If I was in clinical, I'd be around behind the patient, feeling of their hip bones, right? These iliac crests right here. But I'm going to feel these iliac crests on the patient right here. Once you do that, you're going to put your hand on either side of those hips, feel the top of that iliac crest. And if you draw an imaginary line between the tops of those two iliac crests, what they cross over is the L4 spinous process. In case you're curious, that's called Touffier's line. He was some guy that kind of figured that out, right? And so let me show you. Top of the iliac crest, right here, right? If I draw an imaginary line clean through, I'm going to hit the L4 spinous process right there. And that's what you're shooting for. Once you find that L4 spinous process, you can count up, you can count down, and know exactly where you are. All right, so that, just so you know, very common board question. You may get asked that in a regional class. You may get asked that in a clinical practicum exam. Who knows? But a very common question is, if you find the top of the iliac crest, draw an imaginary line, what does that intersect? And they'll say possible answers being the L4 spinous process, the L3 spinous process, the L3-4 interspace, the L2-3 interspace, the L4-5 interspace, and it can get kind of confusing. Again, what it's going over is the actual spinous process, which is this bone right here when you draw that imaginary line across there, okay? So, I don't mean to confuse you with spinous process and interspace and that sort of thing. We'll go over that a little bit more here in a minute, but just while we're talking about it, that's how you can find where you are in the back. So now that we've talked a little bit about how to find out where you are on someone's back, let's talk about the anatomy of the actual spinal cord, nerve roots, specifically the epidural space and the subarachnoid space. There are 3 meningeal layers that surround the brain and spinal cord to serve as kind of a protective layer from that. All right, so those 3 meningeal layers from the outside in, the outermost one is going to be the dura, middle layer is going to be the arachnoid, and then the innermost layer is the pia. The easy way to think about that, the way it was described to me when I was in school, the spinal fluid, their cerebral spinal fluid, lives in the space between the pia and the arachnoid layer, right? So that's where all that spinal fluid is. When you do a spinal block, you're injecting medication into the actual CSF itself that's going to circulate around that spinal cord, and that's what your goal is to find that subarachnoid space, right? The dura, on the outermost layer, is the layer where when the nerve roots come off the spinal cord, they pass through that arachnoid and dura layer and then branch out to the different dermatomes that they innervate, right? As they come through that epidural space, epi being on the outside of the dura, right? They come through that area right there. When you're doing an epidural block, you're going to have your needle and eventually your catheter in that epidural space. So the medicine that you inject right there works on nerve roots rather than the spinal cord itself. Big difference right? And we'll talk about some of those differences here in a minute, but the main difference that you're going to see clinically is the amount of volume of local anesthetic and or narcotic that you're injecting goes up considerably when you're doing an epidural block versus a spinal block, okay? The way to think about those three meningeal layers. So technically, there are three separate layers. Like I said, the dura, the arachnoid, and the pia. For our purposes in the lumbar spinal area, we basically consider the dura and the arachnoid to be fused into one membrane, right? You're either going to be epidural, so on the outside of the dura, or half a millimeter further and you're all the way through the dura and the arachnoid layer in your subarachnoid, right? So you're not really going to be able to appreciate a difference between the dura and the arachnoid layer when you're doing an epidural block or a spinal block, right? You're going to feel one pop, so to speak, as you puncture through that arachnoid layer. Now we know that there are three distinct layers, and they are distinct layers. Everybody knows you can get a subdural hematoma, right, up in the head. Those dura veins that run through there can rupture and you can get a collection of blood between the dura and the arachnoid layer. Very common, right? People, you've probably taken care of a lot of them in the unit. So you know that can happen. But what I'm saying is down in the spinal, or excuse me, the lumbar spinal area, we're considering those two layers fused together, right? So, dura here, arachnoid basically fused together. As you're going in, when you get subarachnoid, so past the arachnoid, that's where the CSF lives. So where's the pia? Well, the pia is directly adhered to the spinal cord and the brain, all right? Unbelievably thin. So the way that was described to us in school is, if you had a brain and a spinal cord, right? Let's say you had them right here, you know, in a piece. You dropped them into a trash bag, like a hefty trash bag, right? Tied a knot in the top. The way to think about that is the dura, is the outside of the bag. The arachnoid layer is the very inside of the bag. The space between the bag and where the brain and spinal cord are, that's your subarachnoid space, right? And then the pia is attached directly to the brain and spinal cord. So the pia actually goes through all the sulci and gyri and things like that in the brain, all the little, grooves and things, and it adheres directly to that. I say all that to say, when we're putting in a spinal or an epidural in the lumbar area, you're going to hopefully take your epidural needle and stop just before you hit the dura, right? That's going to be the epidural space. And technically, if we're being real precise, there is no such thing as an epidural space in most individuals. The epidural space does not exist. It is a potential space. So you're going to create a space on the outside of that dura, just on the outside, between the ligamentum flavum, or the yellow ligament it's called, right here, and the dura. You're going to get your needle right in between those two layers, insert air or fluid, eventually local anesthetic, and you're going to create a space in between there. And then when the nerve roots run through that area, they're going to run through the local anesthetic, narcotic, whatever combination of drugs you've put in there, and that's how you're going to work on those. When you're doing a spinal block, you're going to go through those different ligaments. You're going to pop all the way through the dura, and again, we're considering the dura and the arachnoid to be fused together. So once you're through the dura, you're pretty much automatically through the arachnoid layer into the subarachnoid space. So you're going to be looking in that instance for CSF to come out, right? And then you're going to inject your medication in there so that it can circulate with the CSF, work on the spinal cord, and cause a direct effect that way. All right, you following me so far? Okay. When you're putting your needle in through the back, there's a couple different methods that most anesthesia providers will use. Typically, we'll go what we call midline. So when you identify the interspace that you want to be in, and again, I'll show you all that here in a second, but when you identify that interspace level, you're going to take your needle directly between those two spinous processes and go straight in. It's a straight shot. It's the shortest distance to get to where you're going. And most of the time, it's the easiest approach, because if you'll notice on this model right down here, these spinous processes come off at an angle, right? So if you're coming in midline with your needle, you have to adjust most of the time cephalid and caudid, and that's about it. Sometimes you have to adjust side to side, and we'll talk about all this stuff here in a second. But generally speaking, you come in, you adjust a little bit with a cephalid angle, and you get right up into that intervertebral foramen where you can access the epidural space or the subarachnoid space. There's a second technique called paramedian approach. So if you find that interspace that you're looking for between those two spinous processes, instead of going straight in, you're going to instead come off to the side like this and angle in this way, right? What that does is it gets you around some of the ligaments that are in there. And it's going to be important that you know the ligaments and structures that the needle passes in order to get to the epidural space or the subarachnoid space, all right? Again, you'll go over all of these in your regional course, but I'm going to go over them here too. So when you're doing these blocks and you're going with a midline approach, the first thing that needle goes through is skin, obviously, right? Then subcu tissue, and depending on the size of the patient, that subcu tissue varies greatly in size and dimension. Once it does that, if you have your spinous processes coming down like this, there's what's called a supraspinous ligament that runs directly in front of these spinous processes. So that needle is going to go through skin, subcu, supraspinous ligament. There's a ligament in between those spinous processes, so intraspinous ligament. There's a ligament that ends kind of right here, right in front of the dura. That's the ligamentum flavum. And then you're into the epidural space, right? So again, for an epidural, the structures that the needle is going to go through: skin, subcu, supraspinous ligament, intraspinous ligament, ligamentum flavum. That's with the midline approach for an epidural. Midline approach for a subarachnoid or spinal block: skin, subcu, supraspinous ligament, intraspinous ligament, ligamentum flavum, and then you're going to go further through the dura and the arachnoid into the subarachnoid space. All right? That's for a midline approach. But again, if you want to go off to the side, if you have your two interspaces here and you want to come in at an angle, and again, there's different reasons why you might want to do this. I don't want to get into all of the same stuff that you're going to cover in your regional class, but a lot of times, particularly in elderly patients, you can get calcium deposits in that ligamentum flavum, and it can be very, very difficult to get through to that intervertebral foramen, right? So if you can pull off to the side, you'll bypass some of those calcium deposits, particularly not so much the ligamentum flavum, but in that interspinous ligament, you'll for sure miss those, right? So if you're coming in paramedian, so you're coming in at an angle like this, the structures the needle goes through for an epidural are skin, subcu. Because you're not coming in midline, you're not going to hit that supraspinous ligament that runs in front of those spinous processes. You're not going to hit that interspinous ligament because you're not going between those spinous processes. Again, you're coming off to the side like this. So you're going to hit skin, subcu. There is a ligament that runs down the side, both sides of that supraspinous ligament. That's called, those spinous processes. That's called the paraspinous ligament. So your needle is going to go through again skin, subcu, paraspinous ligament, ligamentum flavum, epidural space. If you're going to the subarachnoid space, skin, subcu, paraspinous ligament, ligamentum flavum, all the way through the dura and the arachnoid into the subarachnoid space. So we've covered the anatomy as far as what blocks are working on what. The epidural is working on nerve roots, a spinal block's working on the spinal cord. We've talked about placement as far as with an epidural block, you're trying to place that needle and eventually catheter in the space that you are going to create, a potential space, an epidural space between the ligamentum flavum and the dura. And then for a subarachnoid block, you're going to go through all of that and deposit a medication in the CSF, right, past the past the arachnoid layer, and that's going to work directly on the spinal cord itself. Let's go back to the model a little bit, and I'll show you some of these different structures that we've talked about, and I'll go over again kind of showing you the difference between a midline approach and a paramedian approach. Okay guys, so here we are back at our mannequin, and so I'm just going to show you some of these things again, same structures that we just talked about. Alright, so looking at this straight on, if you took a needle and went straight in like this, that would be a midline approach, right? Because I'm going right midline, right in the center of someone's back. A paramedian approach that we talked about comes in at an angle like this. So I can still hit that intervertebral foramen, but I'm missing some of the ligaments. All right, so again, just to show you where these ligaments are. So skin, sub-Q tissue, that one's the same whether you're going midline or paramedian. If you're going midline, that supraspinous ligament that I talked about runs right in front of the edge of these spinous processes here. All right, intraspinous ligament that we talked about runs between these two spinous processes right in here in the middle, and then your ligamentum flavum is right back in that area. So you can see if you're going midline, you're coming through skin, sub-Q, supraspinous ligament, intraspinous ligament, ligamentum flavum, right? Again, for an epidural. If you're coming paramedian though, you're coming in through that skin and sub-Q tissue, but as you come in here, you're missing that supraspinous ligament, you're missing the intraspinous ligament. Remember I told you there was a paraspinous ligament, and that runs down both sides of these spinous processes here. All right, so again, with a paramedian approach, you're coming skin, sub-Q, you're going to come through paraspinous ligament into the ligamentum flavum, and then again, if you're going through for an epidural block, you're going to stop right there. Okay, you can also see, I'm going to turn this, so you can see from this lateral view right here, that these spinous processes have a tilt down. So we call that a caudad tilt, right? So they're aiming down toward, basically posterior. And so like I was telling you, if you're coming in midline, usually this angle right here is all that you have to adjust. If you're midline, you come in like this, you hit bone, you back up, you do a little bit of a cephalad angle, and you go straight in. So the thing that makes a paramedian approach more difficult, I'm going to turn this back a little bit. With a paramedian approach, you come in from the side, right? And so you have to basically use your best judgment at what angle this needle needs to be at. Because if it's too shallow, you're going to come in here and hit some of these transverse processes. If you over adjust, you're going to come in over here and hit transverse process. Right? So you really have to do a lot of guessing with a paramedian approach, which is why most people will try midline first. So, say that to say, again, anatomy, spinous processes here, transverse processes are these right out here to the side. The facet joints, the things that these vertebral or these vertebrae articulate on, which allows the back to move, are right here, right? And so when you go to the chiropractor, that's what they're adjusting, are these facet joints right there typically. And so those are the main players that you need to be aware of. All right. While we're talking about this, I'll give you kind of a golden tip right here. All right. Most of the time, epidural space in most individuals is somewhere around 6 centimeters deep. 4 to 6, they'll say, in most individuals. In those that are very, very thin, the epidural space can be less than 4 centimeters. I'll just tell you, here in Jonesboro, that's fairly rare. In the more obese patient, that epidural space can be more to the 6 to 8 centimeter range. And that's how deep it is from the skin, right? So I say that to say, if you are coming in with your needle, right? Let's say you're trying a midline approach. You're coming in with your needle and you hit bone fairly shallow. And we'll go over the process and the steps for this here in a second. But if you come in and hit bone, like you come in, you hit an obstruction and that needle won't go any further. And you're hitting it fairly shallow. And by shallow, I mean less than 4 centimeters, right? Because again, most individuals 4 to 6 centimeters deep, that epidural space. So if you're less than 4 centimeters and you're hitting bone, typically what you're hitting is this spinous process because it's the thing that sticks out the farthest back, right? So if you come in and hit bone at say 3 centimeters, 4 centimeters, that's a real good indication that you're hitting spinous process. And so the way to get around that is to pull your needle back, adjust up to get around that spinous process, and that'll get you into that intervertebral foramen there, okay? So what happens then if you're hitting bone deep? And by deep, I'm talking about typically greater than 4 centimeters, somewhere in the 6 centimeter range, right? If you're hitting bone deep, then chances are it's not spinous process, right? Because at that depth, you're already past where the spinous process should be, right? And so if you're hitting bone deep, most of the time what that means is that you're off midline. Your needle is either too far to the right or too far to the left. And what you're doing is you're coming in here, you've missed the spinous process, but your needle has come in here and hit these transverse processes instead, right? And you can tell that this is what I'm aiming for, and I hit this right here. That's pretty easy to do, right? I mean, we're talking about a centimeter, most of the time less than a centimeter difference right here. So it's very easy for your needle to get off midline, just about a centimeter or so, and you hit bone deep, and that's these transverse process. So if that's the case, you can sit here and adjust your needle up and down, but that's not the best solution. You might be able to adjust it up and squeak in right here on the edge, but usually if you're off midline and you're hitting a transverse process, you need to come out, adjust your needle side to side. If you're hitting bone deep, you kind of assess and say, man, if I'm off midline, maybe I'm off to the left a little bit too far, right? So you come back with your needle, adjust to the right, come right back in, and then you get to your intervertebral foramen, all right? So again, kind of a golden tip here to help you troubleshoot some of these blocks. If you go in and you're hitting bone, because when you're putting these needles in the body, you're either going to hit bone or you're not. And if you're not, you're going to be able to advance that needle just like we're going to talk about here in a second. And that's great. That's what you're shooting for. But if you go in here and you can't advance that needle anymore, then you're hitting a hard obstruction. That's going to be bone. And if you're hitting that bone shallow, again, adjust your needle up and down to get around that bone, right? If you're hitting bone deep, transverse process. Pull your needle back, adjust it left to right to get around that obstruction, okay? Okay, so we're almost done talking about anatomy. Here in a second, I'm going to sit down with one of these mannequins and actually show you how that works, okay? One other little tip. I just gave you the tip about adjusting needle up, down, or side to side, depending on how deep it is that you're hitting the bone, right? The other thing that I'm going to talk about is how to find that inner space that you want. So you can practice this feel kind of at home. You'll be able to feel it on the mannequins that we have, but you can practice it a little bit at home. So if you just take your fist, these knuckles right here, that's what these spinous processes and these inner spaces are going to feel like in the back, right? So they're going to feel like this right here, right? These knuckles, that's going to simulate spinous process. And so if that's the case, if I come in and find this, and we're going to call this L4 spinous process, then the next big bumpy thing above that is the L3 spinous process. The area between those two is the L3, L4 interspace, right? So if this again is L4, the next big bumpy thing down is going to be the L5 spinous process, and the distance between those two is the L4-5 interspace, okay? So when you're feeling of someone's back like this, you're going to feel these spinous processes, and you're going to take your thumb, or what I personally do, I'll take my index and middle finger, and go over those spinous processes and then bring it back together when they come back to midline. That helps me orient myself to what's midline on the body, right? Either way, when you feel these things, you're going to be feeling for what feels like the greatest distance between these two spinous processes. That's going to be a wide interspace, and you're going to have more room to manipulate your needle up and down because, again, most of the time you're going to try to go in midline. So up and down is the type of manipulation that you're going to have to do. So you're going to find that widest interspace in there, okay? Again, we want to put these in below L2 so there's no chance of spinal cord involvement, right? So I'm going to find my L4 spinous process. I go up, L3-4 interspace. If I go up again, that's the L2-3 interspace. And if I can help it, I don't want to put it in above that, right? So again, L4 interspace, I'm going to go down, this is the L4-5, or excuse me, L4 spinous process. I go down, this is the L4-5 interspace. For me, what I recommend to most individuals is to find that L4 spinous process and go either right below it to the 4-5 interspace or right above it to the 3-4 interspace. And the reason is, most of the time, that 3-4 interspace, just in most individuals, feels like the widest interspace, just to be quite honest. And then also, let's say you make a mistake, right? And you go in with this epidural needle and you go too far, and you, instead of stopping in that epidural space or that potential epidural space, you go too far and you puncture it through the dura and into the subarachnoid space. I'll show you in a minute. That's a big needle, and so they're going to have a pretty high likelihood of CSF leak coming out of the hole you just made in that dura and the arachnoid layer, and that can give them what's called a post-dural puncture headache. And that can be a terrible headache that can last a week to 10 days. You go in and cause a wet tap. You come out, the patient still needs the epidural because they have labor pain. Now they're going to have a terrible headache on top of it, right? But you're going to go up an interspace and go in and try that epidural again, right? Or probably if you cause a wet tap, the CRNA or anesthesiologist you're with is going to shove you out of the way and they're going to do it. But they need to be able to go up above that. And the reason is because you made a big, huge hole the size of that epidural needle, which is called a TUI needle. If they go down below that, or if you go down below that, go in and find that epidural space and thread that catheter through. That catheter is small enough to fit inside the needle and get to the epidural space and travel up, right? So let's say it gets to that epidural space, starts to travel up, and the first thing it encounters is that hole you made. Very easy for it to cross right through that hole, and now it's in the subarachnoid space instead of the epidural space. And again, I told you one of the biggest differences that you're going to see clinically between these two blocks is the amount of local anesthetic that it takes to achieve the same effect. So, for example, if I'm doing a C-section on a lady that is, say, 5'9", fairly tall, 5'10", something like that, I'm going to use Marcaine as a spinal, and I'm going to give her 2 cc's, right? And that should get her all the way up to T4. And that's the level that I need for an effective spinal for a C-section. To get that same level with an epidural going in at the exact same spot, instead of 2 cc's, I'm probably going to need 20 cc's of 0.5% Marcaine or 1/4% Marcaine, probably half. So 2 cc's spinal versus 20 cc's in an epidural space to rise up to that same T4 level. And so the danger is if that epidural catheter goes across the dura and subarachnoid in the subarachnoid space, and you give them 20 cc's of local, that's going to rise all the way up, travel past the foramen magnum here, up into the ventricles of the head where the CSF circulates, and cause what's called a total spinal. So it goes all the way up and they lose brainstem control until that spinal wears off, right? So there's ways we're going to go about to know where that catheter is. You're going to give a test dose to hopefully rule that out. But I say that to say, if you create that hole, you want to go to the level above that. And that's why I recommend that you go in either the L3-4 or the L4-5, because if you go in L3-4 and cause a wet tap, you can still safely go up to the L2-3 interspace, go in there, place your epidural, and know that there's no spinal cord behind the area that you're going into. All right? All right. One last tip before I show you the procedure. Again, these spinous processes, I'm assuming that's, we're kind of guessing that's what these are. These spinous processes come down at an angle, aimed, cauded, right? So if they're aiming down toward the butt, basically. When you feel this inner space, right, and you get ready to make your local and go in with your needle, you want to go in just above the inferior spinous process, right? So there's two spinous processes that make an inner space. The one on top, that's the superior spinous process. The one on the bottom is the inferior spinous process, right? You want to go in just above the inferior spinous process. And here's why. If these things are coming down like this, you come in with your needle and you come in just above this inferior spinous process. Let's say you come in and you hit bone. You can come back, adjust your needle up, and pretty easily get into that intervertebral foramen where you're wanting to go, right? But if you make the mistake of going in just below the superior, you're going to come in like this. You're going to miss that because you're below that superior spinous process, and you're going to hit bone. You're going to come back, angle up, and hit bone. And now you don't have anywhere further to go. So you're going to come back, angle up some more, and you're going to hit bone. And you come back and angle down and hit bone. So if you have this inner space right here, right? Find the bottom one, the inferior one, go just above it, and enter right there. And that'll give you the room to make that cephalad adjustment that you need to make, okay? All right, enough talking, enough anatomy. Let's go actually look at the procedure itself.